Good morning. My name is Jim Welch. I'm the Clinical and Operational Lead Nurse for Mental Health Liaison Services, and I'm here today with my colleague Mike Bonner, who is the Clinical Lead for the Children and Young People's Mental Health Service, working in Children's A&E, but also the Paediatric Department here at Gloucestershire Hospital. So we're here today to talk about the mental health services on offer to children and young people in Gloucester Hospitals Foundation Trust, to describe what those services are and the services that both you as members of staff and the patients themselves can expect. So good morning, Mike.
Hi Jim, how's it going?
Yeah, good, thank you. How are you?
Yeah, I'm all right. Bit nervous being on camera. This is a bit unnatural, but it's all good, and hopefully the listeners will have a good time.
Yeah, I've no idea how people do this for a living.
No idea at all. I'd rather just stick to nursing.
Yeah. So thanks very much for your time this morning. Really appreciate you coming in. So I wonder if I can ask you first to describe the role of the Children's Mental Health Liaison Team.
Of course. So we are a team that work predominantly with 11 to 15-year-olds. And we will see children and young people who come to hospital after they've self-injured in some way, might have attempted to end their life, or might be in a mental health crisis. Mm-hmm. The thing about mental health crisis is people often ask, well, what is a mental health crisis? How do we define what that is? And there's been a lot of discussion amongst our team, commissioners and a lot of different people. And at the moment, the working definition of that is whatever the young person says it is. Okay. The reason being is that people can be distressed for all sorts of different reasons, and we're not the ones to put on what person's capacity for that distress is or what that crisis means.
We're not judging that.
Exactly. We don't have that prejudgment of what crisis is. So that might be a bit confusing in terms of who would we or wouldn't we see. Mm-hmm. But the best advice that I can ever give is to give our team a call, because we'll always be open to kind of talking about any referrals or any concerns that people have. Mm-hmm. So with those admission criterion in hand, we will offer a biopsychosocial assessment. Mm-hmm. And the purpose of that assessment is to find out more about the reason for the young person's admission, the wider context about some things that might be impacting their well-being, to do an assessment of risk, and to then think about what sort of support can be put in place within the community setting, usually within the community setting, because our goal is to keep children at home with their families. However, there are occasions where sometimes we do consider alternative ways of treatment, whether that be, for example, in a psychiatric hospital or not, but we try to avoid them. Hence why I'm talking about discharge planning over the admissions. Sure. So we would not just do that independently, but we would work with agencies like CAMS, or other people in the community who might have a role with the Child and Adolescent Mental Health Service, yes. Yeah. Sorry, abbreviations. So we would work with CAMS and other agencies, children's social care, to think about more of a holistic approach or a multidisciplinary approach to supporting young people
within the existing network around the young person, or developing a network around them.
Yes, so sometimes that network will already be in place, sometimes it won't. Mm-hmm. So our role is about establishing what that network is and to think about the plans post-discharge from hospital. Mm-hmm. So the assessments, so we largely will undertake those assessments, but we do have other roles in that we support the hospital or have supported hospital staff, where there might be periods where the young person or the family might be acutely distressed, or where there might be concerns around medication use, or just general queries or questions about how to support a young person who's struggling with their emotional health or mental health and well-being.
Particularly, I think at the moment there's been a role around caring for patients with eating disorders and eating challenges.
Yes, there's a lot of debate or discussion around is it an eating disorder or disordered eating, and they're very distinct presentations in themselves, but we will absolutely have a role in kind of supporting people who may be at risk of medical emergency, I guess, in the sense of because of restricted food and fluid intake. I use the term medical emergency because I'm thinking about the MEAD guidance, which is the medical emergencies for eating disorders, where there's very specific criteria and parameters by which we might assess the risk of compromised physical state or.
And I guess for the benefit of our viewers, the MEAD guidance is available on the vulnerabilities portal of the intranet. So all they would need to do is to go to vulnerabilities portal, go to the homepage, type in vulnerability, and then choose the eating disorder section, and they'd find all of the relevant policies, procedures, and paperwork there uploaded.
Excellent. So yeah, we will have a role in terms of supporting with disordered eating, but the eating disorder service will predominantly work with young people who come in with an eating disorder. So yes, and then the other scope of our role is that we've delivered training, and hence why we're also here as well. Yeah, so I guess that probably explains the main role and function of our team, I think.
And can I ask, so at the beginning you said 11 to 15, so children outside of, under 11 or over 15, can you describe what happens for those young people?
Absolutely. So those who are under 11, the commissioning arrangement is that the Child and Adolescent Mental Health Service will undertake an assessment for someone who comes to hospital with in the same kind of circumstances that we've already described. And either the hospital can contact us directly to liaise with CAMHS, or you can contact CAMHS directly. So they will be responsible in that domain. At the moment, for those 16 upwards, the working age mental health liaison team are offering assessment for those young people. However, where our team have capacity, we will try to undertake those assessments and support the team with that at the moment. We're currently operating a reduced staffing capacity at the moment. So that's why we haven't fully undertaken the 16, 17-year-olds. But when we're at full capacity, it's expected that our team would do that. And but in the meantime, it falls within, it's shared between the two teams.
But I guess ultimately it's the same telephone number, it's the same conversation, it just depends who you're having it with.
Absolutely.
And who picks up that telephone and that referral.
Yes, and so on that note, it's probably important to say that in order to contact us or to make a referral, just give us a call. The number is 0300 422 5490, or just extension 5490. And we take telephone referrals. There's no forms that need to be filled in. What we predominantly need to know, it's who the young person is. We need obviously their date of birth, NHS number. We want to know about the circumstances around their admission. Usually people pick up that from triage. The triage is a great way that you can get most of the information that we would need within that. So we want to know the circumstances around their admission. We need to know what treatment they may need, or investigations that might be pending, just to help us have a guide of when's the most appropriate time to come and do the assessment. We don't exclude people on the basis of being on treatment. So long as someone can sit through the assessment and is well enough to do that. So if someone's vomiting a lot, we're obviously not going to sit down for an hour and have a conversation about the most difficult things or the most distressing things, the reasons why they've come to hospital. We want to give them some time to recover, be well, and be fit for that assessment. But that doesn't necessarily mean fit for discharge.
So historically, one of the criticisms or one of the challenges around mental health liaison was that fitness for discharge was seen as being the standard by which patients would be seen. You would be fit to go, and then we would see you. But you're saying that's not the case. No,
it all depends on the young person, their family, and where they're at. We want to see people as promptly as possible. We know that young people tell us, and their families, that they want to be in hospital generally for as least time as possible. It's not the easiest environment to be in. It's busy. It's difficult, but most young people want to go home as soon as possible. So we'll try to see them as soon as possible, but it's got to be safe, and they've got to be physically well. So we need to know about the investigations that might be ongoing to help us decide what's going on. And usually when people are on their first bag of acetylcysteine treatment, they usually feel quite sick and aren't usually in the mood to see us. So once they've got through the first bag, generally we tend to see people mostly after that first bag, if they've needed treatment, for example, for a paracetamol overdose. So we'll need to know that. And the hospital policy is that a mental health risk assessment is undertaken. That can be found on the intranet, as far as I'm aware, as well.
Yeah, absolutely. Under the enhanced care policy, which is again available on the vulnerabilities portal.
Yeah, so we will see people. Now, for us, it doesn't matter what that risk rating is. There isn't we're not going to say because they're low risk, we won't see them. Every young person who comes to hospital after self-injury in a mental health crisis or trying to end their life should be offered an assessment by our team.
Yeah.
There's no exclusion for that, apart from someone who comes in who might have an eating disorder who needs different treatment and everything
but risk
else.
doesn't determine the patient's opportunity to be seen.
No, it doesn't. So
it's
yeah,
not as if you would say, low risk patient doesn't need an assessment. Everybody is offered the same thing.
yes, absolutely.
Irrespective of their risk level.
Yeah, and that's consistent with the NICE guidance. I think it's NG 225 on the management of suicide and self-injury in children and young people as well. So everyone should be offered that assessment. So we will, once we have that information, we won't necessarily always immediately come to the department. What we're usually doing in that time is we're trying to think about some of the wider things that might be going on for the child. So we're reviewing their care records. We might already be, if we already know, for example, that there is a wider network around the child, whether that be via CAMS involvement, children's social care involvement, we'll be wanting to liaise with their services to find out more about their care and treatment, find out a bit more to help us kind of inform our assessments and inform our assessment of risk. In particular. So we spend some of that time kind of getting that information because it really does help the assessment. And again, the feedback from young people is they don't always want to have to keep repeating their story. So if I'm going into an assessment and getting everyone to repeat themselves, you can not start on the right foot with people. And we're already meeting someone in such an acute period of distress. We want to do what we can to alleviate that as much as possible.
Yeah, and you can get narrative, you can get story fatigue, can't you, as a person sharing their experience, where by the time you get to paediatrics, you may have told 4 or 5, 6 people about what's happened to you today, and being asked to then recount that again can be a tiring experience.
It's one of the biggest bugbears. So I usually start with young people. I say something along the lines of, I know you've already talked about 3 or 4 people, and you can just see them kind of like smile and laugh and like, yeah. And so there is often a lot of reassurance that they get from knowing that we spent that time to kind of review everything, and which is almost a good thing.
So can I ask you, hours of the service are 9 to 5, 7 days a week.
Yeah.
So you're in the hospital every day, but there are so after 5, for instance, and before 8 in the morning, after 5 in the afternoon, before 8 in the morning, your service isn't readily available. So what's the recommendation around children and young people who come to the accident and emergency department after an act of harm, out of your operational hours?
Yeah, that's a good question. And it's an important one because most young people who come to hospital in these circumstances come between the hours of 8 p.m. and 8 a.m. So I think the most important thing I would always think about first, it's remembering that we've got a child who's in need, and there's all sorts of things that we need to think about before we determine what kind of pathway they should be on within the hospital. Yeah. So there's kind of different aspects of the question you've asked. One of it is about process, in terms of what do we do. The one's about who do we contact, and then the other aspect is about our clinical decision making.
Yeah. It's helpful to think about it in those 3 strands.
Yeah. So I think in terms of who might be contactable, the working age liaison team are 24/7.
Yep.
However, I'm just trying to think about the best way of framing it. So they can be there for advice and guidance, but you might not have specific guidance for children and young people.
They're not trained to deliver services to children under the age of 16, for instance.
Sure. So that you might get varying responses depending on the competence or the level of experience of the staff member who's dealing with that. And I don't mean competence like anyone's incompetent. I mean that in the sense of just the experience of working with children and young people. Yeah. And so there's the working age team on extension 5490, or for any queries where there's concerns about the mental state of a young person, there's the on-call psychiatry team that can be contacted on the Wootton Lord switchboard, which is 01452 894 500. So many numbers in my head. I'm almost like, am I recalling the right one? And so they can be contacted.
But realistically, the response of their on-call psychiatrist would start off as being a telephone consultation, and they may come to see the young person in extreme circumstances, but more likely it's going to be advice over the telephone.
More than likely what people are going to advise is that the NICE guidance recommends that an assessment should be undertaken by our team really, and that the young person should wait for that assessment. And that is unfortunate because we know that there are competing needs in the hospital and busyness, bed availability, all those sorts of things. But I think at the heart of this, we've got a young person who's in a crisis, is struggling for some reason, and we need to understand the risk. And we need to understand what's going on to be able to make a decision on what to happen next. And the reason why our team exists is because we have the luxury of time to be able to undertake those assessments. Where in a busy emergency department or on a busy ward, clinicians don't have the luxury of time to do that. And so, you know, when it comes to the other branch we were looking at earlier in terms of the assessment bit, that's the key of being able to determine what do we do next. Because you might have a young person that's saying, I want to go home, or a family saying, we don't want to wait in hospital, please can we go home? Or, yeah, I mean, maybe we could start with that before I go into the other strands, otherwise I'm going to go too tangential. But so I think that there's an important thing to consider here. Well, people have also got the right to decide whether they want an assessment, and how do we make that decision? And that's complicated in the sense of whether someone's 16 or someone's under 16. There's different legal frameworks that we've got to consider within that as well. For the sake of what we're doing now, I'll stick with the 11 to 15s.
Just to say that the assessment of capacity is a legal duty and a responsibility of all clinicians, and that the assessment of capacity policy can again be found on the intranet, and is covered by the Mental Capacity Act.
Yeah, absolutely. So, and particularly for 16 to 17-year-olds, where under 16, the Mental Capacity Act doesn't apply. So this can cause a lot of... it gives us a lot of time to think.
It's confusing.
It's confusing. It gives us a lot of time to think, and it's the decision making isn't easy in this. And people may already be aware that there's the Gillick Competency and Fraser Guidelines. That is, you know, the case law that led to these guidelines about whether people under 16 or how and under what circumstances can they consent to treatment. It gets even more complicated when we're looking at the right to decline treatment. So there's many factors that we've got to consider. Now, if someone's done a triage, usually following a triage, there might be further assessment that goes on by other members of staff within the hospital, and whether that be an ACP or a doctor. And usually a lot more information is gained within those assessments than you get within the initial triage bit, understandably
it's
so.
More comprehensive.
Yeah, of course. And so one of the things that I know that the hospital use, or a lot of clinicians use, and that can help inform decision making in terms of someone's choice to go home, because in this you might identify factors that make you think, well, maybe it is safe for the young person to go home. Maybe it is a better thing for them. And sometimes what they use is called a HEADS assessment, which I can break down. HEADS stands for home. The E is for education. H-E-A. A is for activities. D is for drugs. Then there's a few S's. The first S is for sex and relationships. The second is for self-injury and depression. And the final is for safety and abuse. So within the HEADS assessment, which people can look up in their own time.
So they'll find that again on the vulnerabilities portion of the internet.
Yeah, I don't want to go into all the bits, otherwise this won't be a 20-minute podcast. It'll be hours long. That can be a useful tool to help us think about the wider context of things that are going around for children and young people. And we'll look at why that's important when we come to the why of, well, why do people self-injure? Why
leads people towards that decision?
Yeah, exactly. So we'll get to that in a bit. So if people are saying, I don't want to be assessed, well, that's completely their choice. There can be different contexts to this. For example, there could be a young person who this is their 4th or 5th admission, and they've seen our team a number of times, and they quite frankly, don't want to talk to us again, because we might not be adding any value to what's already going on and what might be going on around them. What they need is medical treatment or assessment, and then to go home.
Or there may be an existing care plan that's wrapped around the young person where your assessment wouldn't necessarily add new information or add value.
Precisely, and in those circumstances, if it was out of hours, for example, you can call the working age, or the ED or paediatrics can call the working age team, and they can say what that plan is. But usually when that's the case, there would be a plan that we would put on Sunrise as well.
Yeah.
Because there would be an MDT team decision, or a decision around what would go on in those circumstances.
So as an ED clinician, young person comes in, says, I want to leave. How do I connect them to follow-up services? How do I make sure they get some mental health support in the community?
Sure. So what would typically happen is if a young person is seen by our team, they kind of, I don't want to say qualify, but in essence they do qualify for a follow-up assessment with the Child and Adolescent Mental Health Service CAMS, which usually takes place within 14 days of a discharge from hospital, or sooner, depending on how our team might assess the risk or think about the urgency, yes. However, if a young person is not seen by our team, they don't qualify for the follow-up because there's no assessment to follow up on.
I see what you mean. Yeah.
If that makes sense, which might sound a bit weird. But they can still have follow-up or be referred to community mental health services. There is an online referral form that members of staff can fill in, or children and their families can fill in as a self-referral.
It's a self-referral option.
Yeah, so if you were to, it's probably just as simple to Google. If you do GHC, Gloucestershire Health and Care NHS Foundation Trust, CAMS referral form, it will be the top of the Google hit. Right. You go onto that. There is a lot of information that's required, and obviously you need consent of the young person, the family, for that. But that's a form that can be filled in, and then what that would do is it would just be a routine referral. If people were concerned about well, that isn't soon enough, it's routine, I would question, why are you sending them home?
Sure.
In the sense of, not because it might not be appropriate to think, well, they might be better at home and there might be still a plan, but if you're concerned about the risk and things not happening, it's probably better to get us to do an assessment, and then you can have the reassurance that there will be a time frame by which the young person's seeing. I would imagine if people were concerned about needing that support, the level of risk might be higher than low, so it might be moderate to high, and within that as well, people are generally seen within that. It's even though it's something that's aimed towards it, that those timeframes are met. We're not seeing many people kind of, for want of a better term, breach or go beyond the 14 days.
But I guess the takeaway point is, if a child and a young person needs to be seen within an unspecified amount of time, then perhaps discharge home with family would be a safe decision. But actually, if you need assurance as the clinician that this young person will be seen within 14 days, then they really need to have an assessment by your team.
Yes, really.
And I know your preference as a service would be for that child and young person to be admitted to paediatrics so that they can have some rest and recuperation.
Yes, I think environment is really key. And my understanding of the hospital policy is that if someone is pending an assessment, and this would be consistent with NICE guidance as well, is that an admission should be considered, and mental health be seen as a medical need.
Yeah. Mental illness is illness.
Yes.
Irrespective of, illness can be treated by a number of different disciplines, but nonetheless we're talking about health and well-being, and as such mental should be treated just as a priority as physical.
Absolutely. Now, within both the emergency department and the paediatric wards, there are rooms that have been kind of risk assessed to think about safety.
Yeah.
But also, I know there's been also thought in terms of making them feel more therapeutic as well.
Yeah.
I think that, what we'll look at probably a bit later as well when we're thinking about distress is that actually, if you're waiting around in a busy department and you're then sleep deprived because you're not able to sleep as much, your levels of tolerance maybe might change, or how much you're able to hold. And if people are already in such a difficult period of their life, to the extent that they've come to hospital because they've significantly hurt themselves, there might be a fragility in what they're feeling. And so there is therapeutic benefit to giving space and making sure the basics of care are met in terms of something to eat and drink, somewhere to sleep, and all those sorts of things. And so I think we can get to we'll get to managing periods of distress a bit later, I think. But we would generally recommend that there is an admission for an assessment.
Thank you.
But obviously that's a hospital decision that is from consultant to consultant, between emergency department consultant and paediatrics, as far as I'm aware.
Sure, thank you. So I guess for people watching, listening to this today, one of the big questions will be, why do children and young people engage in self-injury?
Yes.
And I'd be really interested to hear your thoughts, but also what kind of models, what kind of structure we have around that. And I know we're going to put up a copy of the model on the screen shortly.
Yes. So this is, I get really excited about talking about this, not because I like the fact that people are in the position where they are struggling, but because of, one, I think evidence-based practice it's really important. And so if there's anything that we can do to help and make sense of people's experiences, and then think about what can we do to provide hope or provide a way forward, I'm all for that. And this is why I get a bit more animated about these things as well. So the model that we're going to look at is called O'Connor's Integrated Motivational and Volitional Model of Suicide.
Catchy title.
Yeah, bit of a mouthful, but it's a really, I think it's a great model, because what O'Connor wanted to do when he developed it was to make it testable.
Okay.
And to have aspects of the model that could be looked at in research and say, is there any value in this? Does this make sense? How can this inform policy? How can this inform risk assessment? How can this inform treatment? And so for anyone listening who's really interested in the model as we go on about it, or any of the publications or evidence base around it, if you go to suicideresearch.info, you can find all the different publications on the website. Some of them aren't behind a paywall as well. Good. So you don't necessarily need an Athens account or anything else to get to the research. It's there, which is really good. So yeah, suicideresearch.info. And there's also videos of Rory O'Connor explaining the model. So if I don't do it justice in any way, you can go and listen to the man himself. So it's a model that isn't necessarily developed just for children. Well, it wasn't developed for children. It's developed across the age ranges. And so there's different things to kind of consider. And what I'll do when we look at the model is think about how might that relate to children. And everything else. So what I'll probably do to begin with is, if hopefully this will be the time that they can put the slide on the screen, and what people should be able to see, I'm hoping there'll be kind of three main boxes. There'll be a kind of pre-motivational phase, a motivational phase, and a volitional phase. Okay.
So can you take us into the pre-motivation?
Yes, I will. The pre-motivational phase, it's all about the individual and the person. So there's three kind of parts to it. What people will be able to read is, it will say diathesis, life events, and environment. The diathesis relates to a person's individual kind of biological, genetic and kind of cognitive factors.
So they're internal systems.
They're internal systems. It's who they are. Yeah. And who we are is shaped by our environment and our lived experiences. Yeah. It's not rocket science. But it's a really important thing to go back to. And particularly with children, because what we don't want to do with children is pathologise normal distress.
Absolutely.
It's really important that we think about the impacts of their lived experiences on their well-being and how they're developing as well, because they're depending on, with 11 to 15, that's a very important developmental age, a stage for people. But even before then, there's really important developmental stages that young people are going through that we need to understand what may or may not have been going on for them. And all this will become clear why in a minute as well. So if we're thinking about environment and life events, one of the things that people will automatically come to mind, or will they be thinking about adverse childhood experiences, or ACEs. There could be so many different examples of what might be going on with children and people. We might be thinking about, has there been bereavements in the family? Have there been instances of abuse? Parental separation, bullying, all of these can be significant life events, and people will undoubtedly be thinking about all the other things that children could be going through, and we could be here all day talking about social media and other things as well, and that to actually be considered as an environmental factor, even though it might not seem like, like us, we're in this room right now and this is an environment, but you've got this online world, this other environment, this other world that young people are engaging with at the moment that has a massive influence one way or another. And we could debate, we could do another podcast on social media and children and young people.
I suspect there's an entire series on online safety.
Yeah, probably. We can get callers in, couldn't we? everyone would have an opinion on it. But the environment that a young person's in is really important, and not just in terms of home, but in terms of school. You're thinking about, well, where do they live? What sort of socio-economical background do they come from? What's important to them in regards to their culture and everything, and their personhood? Or does that young person experience discrimination? All these things that could be really massive, shape us. And what this model says is that we need to understand the person, what's going on around them first, because these factors may or may not give vulnerabilities to us in terms of how we may go on to develop thoughts about wanting to harm ourselves or end our life.
So our individual processing of information and the way we view our distress can be coloured or dictated by the environment in which we live and our internal environment as well.
Absolutely. So to give like a quick, easy one is, if I'm bullied and my environment is people don't accept me, or I don't feel accepted by those around me, my internal sense of self could be eroded quite significantly in terms of how I might value myself. As we go to look at other aspects of the model, one of the terms that they think about is something called thwarted belonging. So if then I don't feel like I belong, what does that do for me in terms of where I might be able to build myself back up or not? Really, really important things. I just want to give an example of what O'Connor talks about in terms of, like, for example, in the diatheses aspect of what might make someone, because I was talking about it might make you vulnerable or not. So, for example, people who have high levels of socially prescribed perfectionism, for example, this is where someone might feel like they've got to perform in a certain way socially, or have their own kind of standards that they feel like they've got to meet. That's described to be one factor in terms of someone's like personality that might make someone more vulnerable. And the reason for that, it's about, again, this might link to that sense of thwarted belonging or their own sense of personhood, where they fit, and everything else as well. So there are all sorts of these different factors that are really important. When we go to the motivational phase, I should probably move on to that because we're getting into that naturally. There's different arrows. So people will see on the top, there's defeat and humiliation, which is the link to entrapment. And so what happened, what it suggested, and O'Connor's deriving from Williams' cry of pain model here, is that the feelings of defeat and humiliation can lead to feelings of entrapment that lead to the act of self-injury or suicide. Just for the sake of terminology in terms of suicide, when I'm using the term suicide, I'm talking about any act that is made with the intent of ending life. And everything else, because sometimes people might call it behaviour, parasuicide, or have these other words that are for it. And I think that just for the sake of the conversation and people listening, if they just know that we mean a purposeful act of harm, irrespective of whether someone changed their mind or has differing views.
Or reaches out for help.
Absolutely. So in essence, the feelings of defeat, humiliation, and entrapment can lead to the formation of the thoughts about, I don't want to be here, I can't cope. But in the model, there are these moderators that might make you more or less likely to feel defeated and humiliated, or might make you feel more or less likely to feel trapped. These are the threat to self moderators and motivational moderators. Yep, got that right. So even though the model sees it as quite linear, like a bottom up feeding across, I don't know if Rory O'Connor would agree with me, but I think it's important to know that I think there is crossover between some of these things and how they influence each other. That's not anything we need to argue about, but it's just important when thinking about an assessment, actually what leads to these feelings. That's what we need to pay most attention to. So
almost a step back from the act itself to the factors that may have driven that act.
Absolutely. So because we're looking at why. Why do people self-injure? Why do people come to this? So we have to step back. And this is why our assessments take a lot longer, because we're going back to the whole diathesis, the lived experience, the environment, and then we're looking at these factors too.
And earlier on you mentioned biopsychosocial, which I guess for the benefit of the audience is the biological, the psychological and the social elements of somebody's life, but also the reasoning for their presentation. Yeah,
absolutely. So looking at some of the threat to self moderators, I just want to make sure I'm on the right one. Yeah, they are. There's usually these things are derived kind of within the person, because it will. The model talks about problem solving, rumination, and things like this. So this is all about our cognitions. And this is important with children and young people because the frontal lobe isn't as fully developed, it's still forming, which will have an impact on impulse control and decision making.
Because that's the seat of higher reasoning.
Absolutely. So these are really important factors to think about. Unfortunately, young people are already kind of at a bit of a disadvantage in some ways because that these skills might not come as naturally to them, which also might affect how they communicate with us in clinic or in triage, because they're not going to necessarily be thinking in the same way that we think, and why should they?
And frontal lobe development isn't, it's not a biological marker, is it? It's
No.
It happens at different rates for different children depending on who they are as individuals.
Yeah, and then you can think about things within this as well, about education and learning needs. So if someone's got needs more time to process information, that needs to be factored into the assessment, how they're responding to questions and all those sorts of things as well. But someone's ability to problem solve and think and their level of cognition might affect how defeated they feel because they might already feel like at a loss or they don't know what to do. So if they can't solve the problem, well, the solution sometimes becomes, well, maybe I hurt myself. Maybe I'd be better off if I wasn't here because I can't succeed in life. Sometimes these are the thoughts that people can generate.
Yeah.
And so what we're trying to understand is how do people get to these thoughts? Because that also helps us where we put our treatment as well. With the entrapment part, there's an element by which we're thinking about where do people fit in terms of belonging. Social connection's so important. And people... So obviously, some people are more introverted, extroverted. Some people like their own space. We need to understand what's normal for however anybody defines their normal. You know, we talk about baselines in physical health monitoring, don't we? And what's that person's baseline? Well, we've got to think about, well, what's the person's baseline kind of psychological state, or what they like in terms of their social interaction. Like, why are we the judges of what's normal? In you know, for want of a better term. But what we want to think about, there's two key things within the social domain that we're thinking about, and one is a sense of perceived burdensomeness. Okay. What we mean by that, that was going to be asked. What we mean by that, it's where people feel like they are a burden, or too much trouble for others.
A responsibility that has to be taken by others.
Yeah, precisely. So someone who might feel like a burden is less likely to want to reach out for help.
Yeah.
They might be more insular because they feel like they're just bothering everyone. Or they just think I'm attention seeking. You know, or they've got other stuff on their plate. They don't need to worry about me. Those sorts of things. That they feel like, oh, I'm just too much. I'm too hard to manage. They'd be better off without me. Could be the sorts of thoughts that kind of people generate.
That's leading you down that path of thoughts towards, if they're better off, it would be better if I relieve them.
Yes,
Yeah.
precisely. And then the other is the sense of thwarted belonging.
Which you mentioned earlier on.
Which we mentioned earlier, belong. I don't belong. Where do I fit? Who am I? And there's all sorts of reasons why that could be. None of this is said with a sense of blame or judgment on families, but just to give some examples of families, for example, you could have a family who is struggling because one of their children has got a child with a long-term physical health condition. The young person that we're seeing could be living in the shadow of that, not because they're not loved, not because they're not cared for, but because the emphasis is going on the other young person. They also might feel like a burden because they've got their own needs and, I don't want to disturb them and I'm going to be too much for them because they've got all this going on. Yeah. But where do I belong? I don't get the same level of affirmation because, and that isn't necessarily because the love isn't there, but it's just not met because everyone's burnt out, for example. Yeah. So you can get a sense of where someone might not feel like they belong, or even bullying. And we also know that so many people experience racism, discrimination. If we think about the LGBTQ plus community as well, and we think about people who are discriminated against, these are all really real important things where people don't get a sense that they are valued, included, they have belonging because of the way society or other people may treat them.
Yeah.
And all of these factors, and we can name a heck of a lot more, kind of influence these feelings of defeat, humiliation, and entrapment. And usually it's that with the absence of finding other ways of managing or finding solutions to that people might entertain the ideas of, well, maybe I need to not be here. Maybe I need to end my life. So these are just some factors and how it might relate to children and young people. Now, the third aspect of the model, so we've gone from the first aspect, which is who is the person, and what factors may or may not predispose them to forming thoughts, and then we've looked at the motivational phase, which is how might people form thoughts or ideas about wanting to harm themselves. The next phase is the volitional phase. So this is where we go from thinking to doing. Yeah. So from thoughts to action. And there's a range of factors that might influence someone going from what the technical term is ideation to action.
Yeah, so because thoughts of suicide in and of themselves are not abnormal or necessarily evidence of mental illness.
No, precisely. I mean, hopefully we've covered that within this, is that we're not even talking about mental health diagnoses at this stage. We're just talking about lived experience and what people go through and understandable factors why people struggle. And that doesn't mean we need to pathologise that as an illness.
Helpful. Thank you.
And people can have comorbid difficulties or can have mental illnesses as well. Young people can still be depressed. Yeah. They can still have an anxiety disorder. All these things will confound all the things that we've already been talking about already. Yeah. But one of the things that actually made O'Connor distinct from other people. So Joyner had an interpersonal theory of suicide. What Joyner suggested was that suicide was an epiphenomena of mental illness. And by that he meant that if you really dug into it, people who would be having thoughts about ending their life it was usually because of some form of mental health difficulty. Maybe Joyner is getting, I might misinterpret what he means by illness, difficulty, those sorts of things. We could be talking semantics. But what O'Connor said is that it's not. And what O'Connor's been trying to do within the research is highlight these other factors that it might impact people who want to end their life.
And in and of itself, I think that's really interesting because if you look at the assisted suicide movement in Europe, and particularly with Dignitas, people now or people have for a long time been allowed to choose to end their life in response to a number of different factors. But what we're seeing now, particularly in Sweden, is that not only adults but children as well are being allowed to end their lives by virtue of mental illness.
Yeah, it's massive. And I mean, this goes on to really...
The whole ethics module.
No, there is an ethics module, but it's still really important because there is a question, and this also goes back to do we let people go home or not, of should people have the right to choose whether they want to die? And we're all going to we've got the biomedical ethical principles that we all subscribe to within our practice. And then we've got our own lived experience and our own values and our own thoughts about that, about whether people should have the right to choose. This is massive stuff and everything. But what I think, what I get from my reading of O'Connor's work and is that if we were able to identify the factors of why people feel this way, and we could address them holistically, maybe people wouldn't feel that way. Or they might not make that decision should these other things be addressed. He actually did his PhD, so I'm going off on a bit of a tangent, but this is interesting. He actually did his PhD on suicide notes that were left after people who had died by suicide.
Oh, wow, okay.
And this is where he came up with the idea of the defeat and entrapment, because what people would often say was, I can't see any other way out. And they would talk about these things of it almost being, this isn't fully what I want, but this is where I've got to.
Okay.
And it's some very powerful reading. And he's got a book called When Life is Darkest, Why People Die by Suicide and What We Can Do to Prevent It. It's a really easy read. It goes into his model as well. It's written for everyone. It's not like a book for clinicians. It's not a professional book, but it's professionally written as well. So like it's still academic, but really sensitive and really honest. And it's recommended reading, I would say.
So if I can take you back to that volitional phase.
Volitional phase, absolutely. Yeah. So there should be another slide that we'll put on the screen, because what O'Connor updated the model in 2018 to look at some of the factors that might influence someone going from ideation to action. Now, I won't go through all of them bit by bit.
Be up on the screen, so
it'll be up on the screen so people can
research in their own time.
Yeah, absolutely. But some of the important things, and particularly as it pertains to young people, I think actually all people as well, is impulsivity. Now, there's a lot of debate about the role of impulsivity and is it protective? Is it not? Is it more of a risk factor? Is it not? But we know that people who are more exposed to self-injury or suicide, whether that be because it's something they've done themselves or witness in others, are more likely to go on to die by suicide. But impulsivity is a massive one as well, because if someone's potentially impulsive and they're in acute distress, there might be more vulnerability within that. And again, irrespective of what the intent is behind the act, I think that's sometimes the important thing to recognise. Sometimes we spend so much time discussing and arguing, well, what was the intent? But sometimes the intent doesn't change the risk. Because irrespective of whether someone's trying to communicate that they need help, they could still be putting themselves in very significant places where they could be at risk of significant harm or death. It's a weird one when we're thinking about it in terms of a risk assessment aspect. So impulsivity is massive, and so is fearlessness about death.
So that's an acceptance that death is a preferable outcome?
Yeah, or just I'm not worried about it. But why this is significant is because if there's sometimes a fearlessness, and this couples in with the imagery bit, if someone's imagine themselves to be dead and has this fearlessness about it, sometimes what you can get is what we call cognitive rehearsal. So someone is kind of going over what it could be like, and if you're kind of in that cognitive cycle in that place, you might be more vulnerable to going on and acting and causing significant harm.
So kind of premeditation of the event and the outcome of the event, and not being frightened of that. Yeah,
absolutely. And that's the sort of thing that gets my kind of clinical antenna going off. Like when I hear young people talk about like death in a way that they imagine it, it always does something in me emotionally. I think, oh, sorry. It always does something emotionally, because I'm just like, whoa, that's really massive and really significant. I mean, but the good thing about all these things that we can see here is that once we understand them, and not just in terms of the volitional phase, but in terms of the motivational phase, we can really target our treatment. And that's the point of all of this, is that understanding the why is about going into the nitty-gritty of what's going on. And that, unfortunately, well, not unfortunately, it takes time. I say unfortunately because within the hospital, people don't have that time. But that's why our team's role is really significant, and why it's important for us to do these assessments, even if it means maybe an overnight admission because of how the service is set up at the moment. Because what we get to do is to provide an opportunity for a young person in acute distress to make sense of what's going on and to think about safety and what we can do to build hope and to hopefully see them on a different course in their life. And that's why I'm passionate about this stuff, because this is what we get to do, and that's an amazing thing to be able to do.
And I guess from a parity of esteem perspective, looking at physical and mental health being on a par, there's no such thing as quick heart surgery, is there?
No.
So why would there be such a thing as a quick psychological, psychiatric assessment of a mental health condition?
Sure. Yeah.
Or not a mental health condition, but a social crisis?
Absolutely. So to answer the question, going back to it, why do people self-injure? There's so many reasons.
There's no answer.
There's no quick answer, but what hopefully this model has shown that there are ways that people can form these ideas, and there's a range of different factors that we try to consider. And you don't have to have a mental illness to have these thoughts. And what we need to be doing is thinking about the wider picture, thinking in a trauma-informed way, a lived experience type of way, and sensitively navigating that with a young person. And everything else. So
I'm going to ask what might seem a strange question. I've heard around the hospital and experienced, not just his hospital, I've got to say, the concept that it's kinder to be crueler, in that if people have a less beneficial experience of emergency care, they're less likely to harm in the future. What's your opinion of that?
Oh, that is a deep question. It's interesting because I think that sometimes what we need to do, I don't think that there's a blanket rule that you can give to supporting people in these situations. What I think is that we need to, if we get to the heart of what's going on for someone, and I think one of the terms that we give to it is functional analysis in terms of behaviour. By behaviour, I don't mean that as a kind of negative or derogatory term, or a behaviour seen as bad. It's just what our actions, it's just our actions. So what's the function and purpose of what a person is doing through their actions? Now with children and young people, that can be quite complicated, because sometimes often, and this might be taking us back to like kind of our attachment theory and thinking about relationships, is more often than not, if we go back to this model, if defeat and entrapment leads to the cry and the act, as the Williams model suggests, then often what we're seeing is that people are trying to sometimes seek help because they might not know how else to put all these other things into words. And particularly with young people, and what we see on social media is, well, here's how you can get help. Here's a way to tell others what's going on. It's very powerful. So are we cruel to be kind? And I guess that what's in that question is, are we reinforcing behaviours, or what messages do we give to young people by how firm we are, how empathic we are, or all those sorts of things? I think that the most important thing that we can ever do for someone who is struggling in the periods that we are is be empathic, is to foster hope. Yes, people need clarity and boundaries and things and all those sorts of things. But like, people need to know that this isn't the way. There can be other ways to find or to cope with the things that you're finding difficult. We don't want to reinforce that, of course not. But I think what people need, interestingly enough, there's a book by Bruce Perry called The Boy Who Was Raised as a Dog.
Okay.
And it's a book all about children who've experienced significant trauma and what can we do to support them. And it's a book that will make you cry because some of the examples in there are just horrific. But it's a really poignant book because all that these children, what he's demonstrating more than anything, and this might sound really odd for me to say in a clinical setting, is saying what the children need is love. Children need love. And that doesn't sound very clinical, does it?
I think when you think about the psychological, the chemical process of love, actually what you're talking about is the release of some very incredibly powerful neurotransmitters.
Oxytocin.
Precisely. You're talking about suppression of pain, you're talking about that increased sense of belonging, that reduced volition. So actually love is a remarkably powerful thing.
But to bring in other things that we demonstrate, or how we can demonstrate, basically what we're demonstrating to people is soothing, positive connections, positive attachments. But part of in nursing, our code of conduct talks about how we're supposed to act in terms of our compassion and our care. And so I would argue that actually, people can argue, is it going still back, is clarity and boundaries, is that real kindness? I think people are more susceptible to our own affect and how we operate than we give them credit for. People know or can easily sense whether people are genuine, whether, like a classic one in mental health is people will get wound up, I'm curious. And it's almost like, don't you say that. It almost feels like it's professional, it's become a jargon, even though it's meant in a really lovely way. Like we do want to have professional curiosity, absolutely. So I feel like I'm going all over the place, but I think the bottom line point is I actually think that we probably need to, unless there's a specific reason that's agreed with a multidisciplinary team, because we've got a clinical formulation written about a person's needs that indicates actually no, they don't need to be admitted. What this is doing is feeding something psychologically that we're trying to work on to be met in another way. I think that those are the only times that we do it in that way, when it's agreed and there's a clear therapeutic benefit or other psychological thing that we're trying to treat that is clearly being tried to treat, rather than there's just maybe sometimes using that as a reason not to. Maybe because we're busy or we've got other things that are going on for us.
It could be a self-protective mechanism if a clinician has been exposed to a lot of trauma, for instance, and perhaps has some trauma fatigue, then they can fail to disconnect themselves.
Well, but it's important, isn't it? Because in our work, we've got our own resilience and we've got our own capacity to how much we can hold and tolerate. I have to be mindful of this because I'm talking to children every day about death and dying. And there's only so much of that you can take. And there's times in my mind I'm like, I'm saying this on camera and I don't mind saying it, that I'm just like, oh my gosh, not again. But that level of fatigue can get to us. And that's why our own kind of supervision, our own chance to debrief, our own chance to reflect with other professionals about this is really important, so that we're not in danger of having our fatigue influence maybe some of the decisions or how we might approach an assessment or a young person, or seeing them all as the same, because they're not all the same. Even sometimes we think, oh, this is just another self-harm patient, for example, or it's another overdose, it's another this, it's another that. But as we've seen in the model, everyone's got their own unique, we will all subscribe to, everyone's got their own unique lived experience. Everyone's got their own story, and everyone's got their own way of dealing with the stresses of life. So no, not everyone's going to be the same. Not everyone needs the same treatment, but what we need to do in order to inform our care and our treatment is understand the person. That can only come through thorough assessment, thorough understanding, and doing that collaboratively with the young person and their family.
That's really helpful, thank you. I know one of the questions that listeners or watchers will be curious of, is it getting worse? Is mental health or mental illness in children, is there any evidence that it's building, getting worse? I know, for instance, eating disorder presentations presenting over the COVID period or after the COVID period increased by something in the region of 300%. But in terms of self-injury?
I think in terms of liaison, our data suggests that it's not increasing massively or decreasing massively. I mean, the thing with liaison is that it's very unpredictable. You never know who you're going to get. The only seasonal trends that we do notice in our data, in terms of our referral, what I mean by our data is how many young people we get referred to each month, for example, and different demographics, it's that school holidays seem to be a time that we see less young people, which might go on to say about some of the pressures that school and education and peer relationships and all that brings for young people. I think that a lot's been talked about in terms of the COVID pandemic, and that the impacts on well-being for children and young people, as well as the obvious social media that we've already started to look at. So it seems that services are in a very difficult position, and I don't know if that's because of a rise in acuity or whether the pandemic, because you basically generated a backlog. So the numbers might be inflated because of a backlog, not because of a change in need. There is more awareness. And that has its good points and its not so good points. The good points is that we're normalising things, but the thing is that sometimes everything is seen as mental illness and not everything is mental illness. Like we've already talked about, we don't want to pathologise normal distress.
So there's something around psychological wellness
Yeah.
that isn't about mental illness.
Yes. So I would absolutely say yes. Young people's emotional health and well-being is not necessarily getting better. There's certainly evidence to suggest that. To what degree, with all these other factors that are there, it's hard to say fully what's related, but no one would say that it's not getting. No one would say it's getting better. I would say, but there are. It's also important to know as well, and this might feed into one of the other questions, that there are, and it's really important to remember that there are so many good services that are out there in the community that offer a lot of support, and these are services that people can think about in terms of if they were discharging someone home and they wanted some contingency plan or things to refer young people to, these could be really good options as well. So one of them, for example, in Gloucestershire is something called the Cavern, and they do a youth drop-in every night from 5:30, I think, till 9:30, and I don't know if we can put a website address on the thing. If we can, it will be up there, and it's kftseekers.org.uk. If not, I've just said it out loud and people can do that again.
And they do have a presence in the emergency department.
They do. Yeah, so I was going to say the other way that you can find out more about that service is to speak to the workers from Treasure Seekers who are in the emergency department at the moment.
Yeah.
And what hours are they in the department?
So they are, I believe, in 7 till 11, 7 days a week. And it's a pilot project that's being evaluated, but our hope is that by them being able to do a warm handover or positively connect people to the Cavern services in the community, that actually they'll feel more connected as they go through their emergency department journey. So
Cool.
Really positive, and builds on our earlier work of bringing the Samaritans into the emergency department as well.
Amazing. There's also Young Gloucestershire. Now, there is an amazing project that I am going to plug shamelessly, where they've recently got a pilot project going on where they've got youth workers that work within the paediatric ward. They don't currently work in the emergency department because we're still trying to establish all the data and all that sort of stuff and everything else. But what they do is they not only support people who might remain inpatients in hospital, but they also offer 6 to 8 weeks post-discharge support. Yeah. Which is amazing. And what we have found in the data so far is that they've had a very low re-referral rate in terms of people coming back to the emergency department after we've referred to them. Yeah. There has been some who have, but the numbers are over the 6 months that they've been running so far are really low, and that's really promising, albeit 6 months isn't a long time, you could argue, but so far the data is really promising. So this is a great project.
And I think above and beyond the data, the experience of the children and young people.
Most importantly, and they love it, and why they like it, and the young people's voice is, we like it because it's not very professional. What they mean by that isn't that it's not a professional service, is that they just meet the young people at their level. Yeah. It's not all about assessment and all the stuff that we do. Yeah. For example, it's a lot more dynamic, and they just do great things. Like I'm a big fan of that service. So if anybody wants to know more about that or how to contact them, the best thing is to go through me, I would say, or just give us a call on 5490 and everything, because typically I think the hospital, the paediatrics can make referrals to their service, and so can my team. But we could easily sort out onward referrals for them as well.
Brilliant.
So that's really good. And then there's also, just one more, is that there's something called the Tick Plus counselling service. Yeah. Now, what's really useful for that is even if young person doesn't want counselling, they have a kind of chat service. That's that's online. So if a young person doesn't want to talk over the phone, they can text the service. Mm-hmm. It's not a crisis line, but they have that as a kind of additional service. So if a young person's having a hard day, or just wants to get something off their chest, then that's a really great service for them. They've also got a parent support line as well, which is really helpful as well. And again, Tick Plus as well. They work quite collaboratively with CAMS as well, and are commissioned by the NHS. They're a very reputable service, so you know that you're sending someone to an organisation that's well thought of.
Thank you very much, Mike. Covered a huge amount of information in a very short space of time. Conscious that people will have a lot more questions, and undoubtedly there will be things that we haven't covered today, and people will want further information. Would you be prepared to provide your email address just so that people can contact you directly to ask those questions?
Of course, yeah. My email is mike.bonner, BONNER, at ghc.nhs.uk.
Thank you. My email, if helpful as well, is jim.welch, that's WELCH, at ghc.nhs.uk. So again, thank you ever so much for your time today. We really appreciate it, and I hope our audience have learned. I know certainly, although I work every day with you, I've learned some things today that I didn't necessarily know. So thank you again for your time, and thank you to everyone who's given us their time listening today.
Yeah, thank you very so much.